organs becomes the same color. Yeah. Therefore, protein, which exactly has color, is pigment. Yeah, and we can use term pigmentation. Yeah, according to mixed dystrophy, exactly according to accumulation of this pigment, protein which has color. Pigmentation has the same color as pigment, this protein. Yeah. Pigment could be, we should divide in two groups. If you open, you did homework, yeah, most of you exactly have finished workbook, home task, and in the first page of your home task, you can see tables, yeah. There are classifications of exactly these substances which can be accumulated intra and extracellular at the same time, mixed variant of location we can see. Is it clear or not?
Clear, ma'am.
Yes, teacher.
Yes, ma'am.
Yes. Okay. And first of all, you can see the table about compound proteins. Yeah, these compound proteins, exactly compound pigments. Yeah. We should divide according to origin. Is it exactly here? Is it from outside, from environment, or it is from inside, from internal, exactly, yeah, from inside. If it is from outside, it is exogenous pigment. Yeah, exogenous pigmentation we can see and we can make it even, yeah, in tattoo. If you want some picture in our skin, therefore, we use exogenous pigment substance with color and inject in the skin. Yeah. Endogenous pigmentation exactly develops because of metabolic disturbances in our organism. Substance appears inside, exactly forms inside an organism and accumulates. And according to origin, there are three kinds of endogenous. Now we are talking about endogenous pigment. Pigment from inside, which exactly form inside an organism. They can develop exactly here, yeah, because of hemoglobin destroying, yeah. You know that hemoglobin, this exactly pigment has red color, yeah. And exactly it contains in erythrocyte, and just one pigment and just one red cell in our organism. Yeah, it is erythrocyte because it contains hemoglobin. And hemoglobin inside in erythrocytes, in alive erythrocytes, you know that there are two types of hemoglobin. Oxyhemoglobin and carboxyhemoglobin. Yeah, they have different color, and therefore, according to them, we can see we can identify different vessels. Yeah, arterial blood they contain, and it has bright red color because of presence of oxygen. And venous blood, which exactly, yeah, erythrocyte and are rich in carboxyhemoglobin, and carboxyhemoglobin has bluish color. Therefore, yeah, we can see these blue vessels. There are venous vessels, yeah. But if something happened, something wrong happened, yeah, with erythrocyte, and erythrocyte destroy, usually and normally, yeah, erythrocyte should live, and tell me please how long exactly erythrocyte can live?
Days.
What is it? Yeah, 120 days. After 120 days, yeah, exactly develops apoptosis, physiological death, yeah. And in this period, exactly, erythrocyte and the hemoglobin inside erythrocyte destroyed, yeah, and from it we can see normal hemoglobinogenous pigments. Yeah, it happens all time, every day. Yeah, because our erythrocyte, yeah, should die today or tomorrow. It depends, and every day destroying of erythrocytes happen, and therefore presence of hemoglobinogenous pigment which are originated from hemoglobin. Yeah? It could be normal, and therefore you have to know 3 normal physiological hemoglobinogenous pigment. It is hemosiderin, bilirubin, and one more,
Ferritin.
hematoidin.
Ferritin.
Ma'am, ferritin.
Hematoidin
Yes.
is hematoidin is pathological, maybe.
Yeah, it's pathological. Yeah. There are 6 at all as general, and just 3 we can see in healthy person. But in truth, porphyrin, but very little concentration. Yeah, normally we can see a few porphyrin in healthy person. Yeah, but in porphyria, disease. Yeah, in disease we can see too much porphyrin, and according to this situation, therefore we are talking about porphyrin as pathological pigment. Okay, therefore, normally we should, according to apoptosis and physiological destroying of erythrocyte, usually we can see 3 pigments: ferritin, bilirubin, and hemosiderin. Yeah, but if something wrong happens, yeah, and erythrocyte should destroy earlier, not in the end, yeah, for example, in 90th day, yeah, or 50th day, something happened, yeah, malaria parasite, for example, comes in the blood and destroy erythrocyte. And we can see too much, exactly, for example, hemosiderin in the end. Yeah, after a few weeks, we can see in the blood or in tissues too much hemosiderin because of it. Yeah, therefore, in this situation, we have to talk about hemosiderosis. Is it clear?
Yes, ma'am.
Yeah. And also you have to know 3 pathological hemoglobinogenous pigments. Usually we can see them just in pathology, only in pathological condition, yeah, in diseases. There are hematins, hematoidin, and porphyrin.
Okay.
Is it clear? Yeah, you know it, I think. Yeah. It is about hemoglobinogenous pigment, but as general, there are 3 kinds, yeah, according to origin: hemoglobinogenous pigments, lipidogenous pigments, and proteinogenous. Yeah,
Okay.
it depends which exactly from where it is originated. Yeah, hemoglobinogenous pigments originated from hemoglobin, from erythrocyte destroying. Lipidogenous pigment, they develop because of lipidous membrane, exactly, and lipid destroying, yeah, and they contain lipids. And the last one, proteinogenous or tyrosinogenous, because of destroying of tyrosine. In melanocytes, exactly, it happens. Yeah. Okay. Therefore, first of all, we have to talk about hemoglobinogenous pigments. pigments which are originated from hemoglobin. Yeah, I have named 6. Yeah, and we should divide physiological and pathological. About physiological, yeah, bilirubin, hemosiderin, and ferritin. We can observe exactly increasing their concentration in diseases, in 3 diseases exactly, yeah, hemosiderosis, hemochromatosis, and jaundice. But jaundice, it isn't disease, it is pathological process and even clinical symptom. First of all, let's start from hemosiderosis. And hemochromatosis is very similar diseases. The main difference between, because both of them characterized by excessive amount of hemosiderin in tissues, and it happens everywhere. It is generalized hemosiderin, like hemosiderin accumulation. Yeah. If it is local, if just in some tissue, in one organ, we can see hemosiderin accumulation, it is hemosiderosis. Yeah. We should classify hemosiderosis according to spreading, according to where exactly can we find hemosiderin deposition. If it happens everywhere, it is general hemosiderosis, yeah? And if it develops just in one organ, it is localized, local hemosiderosis. They develop because of different mechanisms, exactly, yeah, but the main reason of every hemosiderosis, it is hemolysis. This hemosiderosis develops because of hemolysis of erythrocytes every time, yeah, always. It exactly caused by hemolysis, yeah, but if hemolysis of erythrocytes develops inside in bloodstream, in blood vessels, yeah, we should identify the position of hemosiderin everywhere in all tissues and organs. Therefore, it will be general hemosiderosis. And it means the name of this condition, yeah, which exactly leads to general hemosiderosis is intravascular hemolysis. Therefore, the direct cause of general hemosiderosis is intravascular hemolysis. Inside intravascular vessel hemolysis, destroying of erythrocytes. Is it clear?
Yes, ma'am. Yes, ma'am.
Yes? Okay. Very nice, because it's very quiet and I don't understand who I'm talking with. Okay, therefore, about local hemosiderosis, if it develops just in one organ or even in some patches, for example, just in one part of the skin, yeah, it develops because of extravascular hemolysis. Yeah, it means that blood and erythrocytes exactly, yeah, go out from exactly the vessel, and outside of vessel in tissues, yeah, erythrocytes and hemoglobin in it is destroying, and from it hemosiderin is formed. Exactly, we can, as example of local hemosiderosis is bruise, yeah, hematoma. If we, for example, if some trauma happens, yeah, and just once some part of vessel is destroyed, blood goes out from the vessel, hematoma, local blood accumulation in tissue happens, and yeah, do you remember, because exactly there are 4 stages of bruise coloration, and we can exactly divide. Yeah, first of all, if trauma happens directly now, yeah, therefore, which color in first phase of bruise development can we see? What
Pink.
color? Pink? Is it pink?
Red.
Ma'am,
Red.
red.
Red color. Yeah, dark red. Yeah, red color because of blood, because of hemoglobin. Hemoglobin. And firstly, it is oxyhemoglobin because it is oxygenated. Yeah. Okay. Therefore, red color. Next. In the next day, after 2 days, what color
Blue.
should we see?
Dark
Blue.
brown, ma'am.
Color. Not brown, blue color. Why?
Due to
Cyanosis, ma'am. Due to hypoxia.
oxyhemoglobin.
Carboxyhemoglobin, because oxygen from oxyhemoglobin is used, yeah? Tissues, exactly, yeah, will take this oxygen and instead carboxy will be connected. Yeah, therefore it becomes bluish because of carboxy hemoglobin accumulation. Okay, next color.
Yellow with the
Brown.
green.
Green because of biliverdin accumulation, because hemoglobin destroy, and there are a lot of biochemical reaction, and one of them lead to biliverdin accumulation. And biliverdin, it doesn't contain ferrum and it has green color and gives green color exactly, yeah, in this place. Therefore, after a few days, we can see greenish color of the bruise, yeah. But have you seen sometimes that this bruise becomes like violet? Have you seen it or not?
Yes, of course.
Yes, ma'am.
Yeah, and how does it happen? How violet color exactly?
And due to mixing of oxyhemoglobin and carboxyhemoglobin.
Yellow.
Due to mixing of two colors.
Two colors. What two colors should we mix to exactly, yeah, to see violet color?
Red and
Yellow.
blue, ma'am.
Blue and green.
Blue and red.
Red and blue.
Blue and green.
Red and blue. Yeah, red and blue. Yeah, it's correct. And how is it possible?
Ma'am, due to mixing of blood.
How is it possible? Therefore,
Maybe.
between, yeah, after firstly, it is always red. Yeah, as next step, after 1 day, it becomes blue color. Yeah, and after a few days, it should become a green color. But in the patient, we can see that after, for example, after blue color, it becomes violet color. How is it possible? We should mix this in the second phase. Yeah, we should mix blue color with red color. How is it possible? Additional trauma.
Mixing of oxyhemoglobin and
Yeah, but oxyhemoglobin can come from blood. How is it possible? New trauma, new blood vessel trauma injury, and oxyhemoglobin goes out from vessel, mix with carboxyhemoglobin, and we can see violet color. Is it clear?
Ma'am, I have just one question. So for getting violet color, you have to hit again at the old trauma point. So let's just say I have a trauma in my hand, and I have to hit that place again to get violet color.
We don't have to do it.
How would I get? Sorry.
We don't have to do more trauma.
So how?
But yeah, but if patient, yeah, has one more trauma exactly at in the same place, and new blood vessel is destroyed, and the hematoma is mixed because of appearance of new blood and oxyhemoglobin. Is it clear or not?
It's clear. Thank you.
Yes, but we shouldn't do it. Yeah,
Yes.
it isn't normal. Yeah, because patient should be very, very polite according to this region. Yeah, don't do more trauma exactly. And the last point after biliverdin convertation exactly changing. Yeah, the last point, fourth, in the end of this bruise development, we can see yellowish brownish color. Yeah, because of hemosiderin. The hemosiderin, it is the last pigment which exactly forms because of through a lot of biochemical reaction, and it will be in the last stage of bruise development. Yeah, is it clear? It is the most stable pigment. And after a few times, this bruise becomes lighter, yellowish, and lighter. And in the end, it will disappear at all because macrophage exactly engulfs this hemosiderin. Is it clear?
Yes, teacher.
Yes. Okay. General hemosiderosis, it is caused by intravascular hemolysis, and we can see hemosiderin accumulation everywhere, in every organ and tissues. It happens because of something wrong happened in the blood, exactly in bloodstream. Therefore, usually we can see it. It can happen. It can develop. In infection diseases, for example, malaria, sepsis, in if we use another blood, in blood transfusion, but it was mistaken and we took another blood, not, for example, patient has second group, and RH, rhesus negative, but it was mistaken and we use first blood minus, R minus. Therefore, it will be conflict inside in bloodstream between erythrocytes, and destroying of it. Erythrocytes happens exactly in bloodstream. What else? Poisons, poisons, which exactly can come in organism and exactly in bloodstream also. The poison can destroy erythrocyte. Leukemia. In leukemia also tumor cells are exactly blood cells. And it's possible that destroying happens of all blood cells and especially erythrocytes. If mother is for example is negative, R negative, RH negative, and fetus is positive, therefore it should be between mother and child, the kid, it will be conflict, RH conflict, because this RH, it means protein in superficial erythrocyte membrane. In child, protein is present. In mother organism, it is absent. Immune system of mother's immune system, can see this protein and against this protein, RH, start to produce antibody, and antibodies exactly in the child organism start to destroy these erythrocytes. First of all, in these children in childbirth, exactly, we can see jaundice. And later, a little bit later, after a few days, weeks, it will be general hemosiderosis. Okay, about hemosiderosis, is it clear or not?
Yes, ma'am.
Yes. Okay. Hemochromatosis. Yeah. Morphologically, it's very similar to general hemosiderosis, because in hemochromatosis we also can see deposition, yeah, too much of hemosiderin. But also, ferritin also should be accumulated. Not too much. Predominantly, it is hemosiderin accumulated in the everywhere. Yeah. But the main difference between hemosiderosis and hemochromatosis, because they are very similar, yeah, it is exactly origin, which from where this hemosiderin appears. In hemosiderosis, it is from, tell me please, from where?
From erythrocyte.
From hemolysis, yeah, from destroying of erythrocytes, yeah. But in hemochromatosis, it develops because of excessive absorption of ferrum in the intestine. Is it clear?
Yes, ma'am.
Because ferrum is absorbed. Yes, some part of ferrum is exactly, it's formed because of physiological hemolysis. Yeah, and another half of ferrum, which exactly we need in, it is come from food, and it absorbed in the intestine. But if too much ferrum comes, yeah, exactly, absorbed, yeah, excessive absorption of the ferrum in the intestine lead to hemosiderin formation. From ferrum, yeah, will be formed ferrum containing pigment, and it is hemosiderin, and hemosiderin is accumulated in tissues everywhere. But the main clinical manifestation, it's like a clinical triad in hemochromatosis. Very often it is hereditary, yeah, because of some hereditary enzymopathy. But also it could be acquired. Yeah, therefore there are two kinds of hemochromatosis. Primary, it is hereditary, and secondary. Secondary, it is exactly acquired. Secondary happens in if patient use too much ferrum-containing drugs, for example. Yeah, sometimes in women it happens. Women are scared by ferrum deficiency anemia, and they can use too much ferrum-containing drugs, yeah, to prevent this anemia. But for, yeah, they can have another problem. Yeah. Also, it can happen after stomach, part of stomach removement. Yeah, for example, if patient has some tumor in stomach and resection of stomach was done. Yeah, after that, it's in long time food exactly. Yeah, locates in intestine, and excessive absorption can happen. Also in liver diseases, in intestine diseases, also we can expect the hemochromatosis development. And the main clinical manifestation of hemochromatosis, this clinical triad, yeah, bronze, because it has like bronze brownish color, yeah, bronze diabetes, because of pancreas injury, bronze cirrhosis because of liver injury, and bronze skin. Three main symptoms. Yeah, bronze diabetes, bronze cirrhosis, and bronze skin. Is it clear?
Yes, doctor, it's clear.
Therefore, tell me, please, like conclusion, what is the main difference between hemosiderosis and hemochromatosis?
Origin, ma'am.
Ma'am, where
Origin.
the hemocyte movement
What
comes.
exactly?
Origin of
In
Hemosider-
hemosiderosis, it is due to hemolysis of RBC, but in
Yeah.
hemochromatosis, it is due to increased absorption of iron in the intestine.
Excellent. Very nice. Okay. Next, what should we talk about? About hemosiderin. How can we recognize hemosiderin at all? Yeah. Hemosiderin. It is what color it has?
Golden yellow.
to brown yellow. Golden to brown yellow.
Golden brown yellow. Yeah, golden brown usually. Yeah, it is exactly. Yeah. And because of hemosiderin accumulation, we can see brown color. Yeah, like a brown color of this organs, tissue. It becomes brownish. Yeah. But if you remember, we have talked already about brown atrophy of the heart. Yeah. Which pigment is accumulated in brown atrophy of the heart?
Lipofuscin.
Lipofuscin. Lipofuscin is also brown color. Yeah. Ferritin is brown. Melanin can be brown. Yeah. There are too much pigment. Therefore, if we can see brown pigment accumulation, yeah, brown pigment exactly, we have to understand which exactly pigment is it. Yeah. Therefore, we have to use additional some specific staining, yeah, like we have talked about them in fat dystrophy, yeah. What staining should we use in fat dystrophy?
Sudan.
Sudan 3, Sudan
Tal.
4,
Or osmic acid.
Yeah. What specific staining should we use according to according to amyloid?
Congo red.
Congarec, teoflorinum, yeah,
Iodium
metachromacy.
sulfate.
Yeah, very nice. Yeah. Yeah, I have very nice students. Okay, and therefore, according to hemosiderin, we also have to use specific staining. What staining is it?
Prussian blue.
Persian blue reaction or Pearl's reaction. Yeah, to name Pearl's reaction or Persian blue reaction. Yeah, Persian blue. This staining has blue color. Therefore, pigment, if we use it, becomes blue color. Is it clear?
Yeah.
If we use Persian blue reaction, yeah, for example, we saw that pigment, brown pigment was accumulated in cells, exactly in tissue everywhere, yeah. We use Pearl's reaction, and if we can see blue color, therefore, yeah, our conclusion is hemosiderosis, yeah. But if we use Pearl's reaction, but it isn't blue, it has the same brown color. What it is? What can it be?
It can be anything.
Lipofuscin.
Lipofuscin. Yeah, according to lipofuscin, what specific staining should we use to understand that it is exactly lipofuscin?
Ma'am, Sudan.
Yeah, because it contains lipids. Therefore, we have to use a specific, osmic acid or Sudan 3. Yeah, is it clear?
Yes, ma'am.
Yes, ma'am.
Yes, very nice. Okay. Next, what should we talk about? But I think that we should be interrupted in any moment. Yeah. Okay. Okay, let's continue. Are you ready?
Yes.
Yes. Okay, let's continue. Yeah, we have talked about hemosiderosis, hemochromatosis. Let's continue about hemoglobinogenous pigments. Therefore, next pathological condition which develops because of physiological hemoglobinogenous pigments disturbance is jaundice.
Okay.
Jaundice, it is a pathological condition. This is exactly clinical symptom, which exactly characterized by yellowish of skin, mucosa, changes of color of stool and urine. Yeah. But the main what should we exactly investigate clinically in patient? It is yellowish color, yeah, of skin, mucosa, exactly scleras. Yeah, it is the main in investigation in jaundice. Jaundice, it is a pathological exactly condition caused by hyperbilirubinemia. It happens because of increasing amount of bilirubin in blood, exactly. Yeah. But you have to know there are two kinds of bilirubin: conjugated and unconjugated. Yeah. Or direct and indirect. Direct bilirubin, it is conjugated one. Indirect bilirubin, it is unconjugated. Okay, but exactly conjugation, transformation of direct bilirubin, non-conjugated bilirubin in conjugated happens in hepatocytes, in the liver, inside in the liver cells. Because just in hepatocytes, glucuronic acid is present, because exactly glucuronic acid association exactly like fixing to unconjugated bilirubin, yeah, leads to conjugation of it. Therefore, conjugated bilirubin, it is combination, connection of unconjugated bilirubin with glucuronic acid. And this combine, connecting happens in hepatocytes. Is it clear?
Ma'am, can you explain just once more? I'm just confused with like direct is conjugated, indirect is unconjugated.
Yes.
And
this conjugation leads to jaundice.
No.
can you just explain the
Jaundice,
once again?
it is hyperbilirubinemia. And different kind of jaundice could be. And in one jaundice, we can see too much indirect bilirubin in the blood. In another jaundice, it will be too much direct bilirubin. Is it clear? But bilirubin, bilirubin is increased. Yes.
So in this both direct, indirect, does it have any kind of difference, clinical symptom difference, or just same?
Yeah, we will talk a little bit. Yeah, but not exactly. Yeah. I can explain according to, we can differentiate it according to exactly our, because if patient has white skin, it's easier to understand which kind of jaundice is it, because different yellowish color, yeah. In another situation, it will be more difficult, yeah. But we will talk about every of them. Therefore, first of all, did you understand what is the difference between direct and indirect?
Yes, ma'am. Ma'am, I have a question.
When the
Yes.
conjugation of bilirubin occur, it causes the connection of unconjugated bilirubin with glucuronic acid.
Yes.
Okay, thank you.
Yeah. Erythrocytes, yeah, after it lived 120 day, apoptosis develops. And because of apoptosis, destroying happens. Yeah, where most, which organ? I mean, mostly destroying of it erythrocyte develops. Where does it happen?
Spleen.
Please repeat.
Spleen, mostly in the spleen, but also in the liver, a little, yeah, and even in bloodstream, a few erythrocytes, yeah, it's possible that they don't have enough time to come exactly in the spleen, and they destroy it in bloodstream, yeah, and because of destroying of erythrocyte directly, yeah, which kind of bilirubin should we see at the same time?
Unconjugated,
just-
indirect.
Indirect,
Unconjugated.
unconjugated bilirubin.
Direct.
Unconjugated, yeah, because after that, after appearance from spleen, yeah, albumin helps this bilirubin because albumin takes this unconjugated bilirubin and exactly go to the liver with it. It exactly, yeah. Is it clear?
Ma'am, we said that it's indirect type when it's destroyed in the blood vessel.
Indirect. Yeah, indirect.
When destroyed in blood vessel.
Albumin helps to travel to unconjugated bilirubin from spleen, from bloodstream to the liver. And in the liver, unconjugated bilirubin comes into a hepatocyte, connect inside in hepatocytes with glucuronic acid, and come out from this hepatocyte direct bilirubin. And it goes in bile ducts and bile bladder. Is it clear?
So ma'am, by that way, the indirect type convert into direct type.
Yes.
It's a progression.
And after that,
it's a progression. Then I'm just saying like statement. It progress into direct type. I'm just saying.
It isn't progression because it is bilirubin metabolism. Because exactly direct bilirubin, it is component of bile. And bile comes in intestine, yeah, and helps for exactly this digestion. And after that, it is eliminated from an intestine. Direct bilirubin. Is it clear?
Yes.
Yes. Okay, tell me please, in healthy person, which bilirubin mostly, we have to see two bilirubin, but mostly, which bilirubin exactly prevail in it?
Conjugated. Conjugated one will be.
Conjugated, yeah. A few unconjugated we can see, yeah, but conjugated because from hepatocytes some direct bilirubin goes in bile ducts, yeah, and some of them go in the blood. Therefore, we can see bilirubin in the blood. It should be mostly exactly direct bilirubin. Is it clear?
Yes, ma'am.
Okay, there are three kinds of jaundice, yeah, prehepatic or hemolytic, hepatic or parenchymal, and post-hepatic or obstructive, mechanical or obstructive jaundice, three kinds of jaundice. Yeah? The difference between them, first of all, it is cause. They have different causes. Also, they are characterized by different biochemical picture in the blood, different kind of hyperbilirubinemia. Is it clear?
Yes, ma'am.
Yes.
Yes. Okay, therefore, the first one, prehepatic jaundice, or exactly hemolytic. Yeah, from this name, you can understand that it caused by intravascular hemolysis. Yeah. When can it happen? Give me examples.
Then okay. Leukemia,
Leukemia. I have talked
malaria,
about malaria,
RH incompatibility,
sepsis, poisons, hemolytic poisons. Yeah. Okay, what else?
RH incompatibility, ma'am. Rhesus.
Yeah. Okay. Is it clear? Yeah. Firstly, this patient has jaundice, and after a few days, weeks, it will be general hemosiderosis. Is it clear? Is it clear
ma'am.
or not?
Yes,
Yes.
ma'am.
Yes, ma'am.
The combination in one situation, we can see two different processes. Yeah, two different diseases. Okay, hemolytic jaundice caused by exactly hemolysis, intravascular hemolysis, and which kind of hyperbilirubinemia should we investigate in it? What bilirubin?
Unconjugated bilirubin.
Unconjugated, yeah, indirect, yeah. We have seen hyperbilirubinemia and too much unconjugated bilirubin in the blood, yeah. Usually, if we are talking, for example, here, for example, for our white skin, it becomes lemon-like color. Yeah, it's very, according to others, jaundice, it is lighter because indirect bilirubin, it is lighter than direct. Direct bilirubin, it has dark yellow, even greenish, yellow-greenish color. Is it clear?
Yes, ma'am.
Yeah, and therefore skin and exactly, yeah, another situation it will be okay. Next, parenchymal jaundice. Parenchymal jaundice or hepatic jaundice develops because of injury of hepatocytes. Exactly. Problem in the liver, in bloodstream, is everything okay, but in the liver it is a problem. Yeah. Therefore, we can it can occur in liver diseases, liver cirrhosis, hepatitis, hepatosis. Yeah, liver cells, hepatocytes are injured, and coagulation, not complete in and not in every hepatocyte. Yeah, exactly. Conjugation of bilirubin happens. Therefore, in bloodstream, we can see mixed kind of hyperbilirubinemia. Yeah, it will be a half, the same amount, a half of indirect and a half of direct bilirubin. Is it clear?
Yes, ma'am.
Yes, ma'am.
Okay, and the last jaundice, which you have to know, it is post-hepatic jaundice or obstructive mechanical jaundice. It happens because of problem in bile ducts and bladder, gallbladder, yeah? Because of cholestasis, it means bile stasis in the duct and the gallbladder, yeah? In gallstone diseases, for example, yeah, if stone was formed in gallbladder, blocked exactly the duct, and bile cannot be eliminated from gallbladder in the intestine. too much bile is accumulated in gallbladder, comes in the bile duct, in the liver also. They are accumulated excessive amount of bile, and bile penetrate through the wall, bile duct wall, through hepatocytes, yeah, and even microscopically we can see, and in distant work exactly you had this. I don't remember the task, what number of the task, but you had a microspecimen of obstructive jaundice, and even we saw some deposition of biles, exactly, like islands, like, yeah, not islands, like lakes of this bile between hepatocytes. And in exactly in hepatocytes, in extracellular spaces, we can see accumulation of direct bilirubin. The same happens in the blood, yeah? It will be hyperbilirubinemia because of increasing amount of direct bilirubin. At the same time, exactly in obstructive jaundice, we can see changes of stool. Stool becomes white color because bile cannot be eliminated, yeah? And this patient has white stool. And urine, dark beer-like, according to the color, this urine, because of presence of direct bilirubin. Is it clear?
Yes, ma'am.
Yes. About hemoglobinogenous physiological pigment, you don't have questions, I hope, yeah? Okay, therefore, let's continue. Let's talk about pathological hemoglobinogenous pigments. There are 3 pathological. We can see them in pathological condition, in diseases, yeah? It is hematidine, hematins, and porphyrin. Hematidine. First of all, you have to know that hematidine develops because of extracellular hemolysis. It means it happens usually in necrotic tissue, in very large hematoma, in big infarctions. In the central part, yeah, we can see only dead cells, necrosis. And if blood goes and penetrate these necrotic masses, yeah, erythrocytes, they appear exactly around, they appear inside in necrotic masses. Yeah, we can see just dead cells exactly, yeah, around them. And extracellular, it means that it isn't inside the cell, they start to destroy. Because of it, we can see hematidine accumulation, yeah? Exactly only in central part of big infarction or big hematomas, very large hematoma, just in central part we can see hematidine. The main feature of hematidine, it doesn't contain ferrum. Therefore, if we use Pearl's reaction, what can we see?
No changes. No changes.
No changes. Yeah, it will be the same as was before. And very often, if we use Pearl's reaction according to large infarction, in central part it will be the same as was before, and the hemosiderin will be just in peripheral part. It will be bluish color, yeah, because of accumulation of hematidine in central part. Okay, next, what should we talk about? About hematin. And you have to know 3 hematins. 3 hematins. they exactly we can see them in different diseases. Yeah? The first one is hemamelanin or malaria pigment, because exactly hemamelanin, it is pathological hemoglobinogenous pigment which occurs in malaria because of exactly destroying of erythrocytes, because malaria parasite destroy erythrocyte from inside. Hemamelanin has very dark gray color, and therefore tissues, if it is accumulating, it becomes dark gray color. Is it clear? Just one disease is characterized by it. Yeah. Next, hematin we can see in stomach. This chloric hematin or hemin. Chloric hematin. It has a black color. And usually we can observe it exactly because of ulcers, erosion and ulcers in the stomach. Yeah. And usually exactly bottoms of ulcers and erosion are exactly impregnated by hematin, chloric hematin, and they have black color. If we cut the stomach, for example, in autopsy, yeah, or for example, in gastroduodenoscopy, we use this apparatus go inside in the stomach, and we can see some areas of black color. They are erosions and ulcers, yeah, because of impregnation of chloric hematin. Then they become black color. In stomach ulcer, sometimes if bleeding develops in patient as complication of stomach ulcer, if a very big large vessel is destroyed and large bleeding develops, patient has vomiting, and this vomiting coffee-like dark brown color. Yeah, vomiting mass is because of presence of chloric hematin, or sometimes bleeding doesn't lead to exactly vomiting. All this blood from stomach goes in intestine, and in this patient we can see black stool. It will be symptom, black color stool, because of presence, and the name of this black stool is melena in Latin. Yeah, melena. Black stool, and it is symptom of stomach ulcer, and it develops because of presence of chloric hematin. And the last hematin, it is formalin hematin. Unfortunately, we have online classes, yeah, but I hope that we will have offline classes, and we will be in our department, and you will see macro specimens, because exactly in our rooms, yeah, there are a lot of macro specimens, different organs, yeah, and we don't see in every of them red color because of presence exactly of formalin, because formalin destroy exactly this erythrocyte hemoglobin and another pigment, and they have gray color, black gray color, and therefore in macro specimen this area which in autopsy should be red color, in macro specimen in formalin it is grayish black color because of formalin pigment formation. Is it clear?
Ma'am, example.
The dark brown or the blackish gray color? for the formalin pigment.
Formalin, it is grayish black.
Okay.
Ma'am,
Okay.
example is for formalin. Formalin
Example?
of disease. Like we are telling about chronic.
It isn't disease. It isn't disease because formalin we can add just after death, after we eliminate this organ. It is exactly.
Not
It
occur
isn't
normally.
disease.
Okay. It's
Just
not.
in investigation, yeah, in macro specimen, yeah, because you have to describe it and you have to know that it is black or gray color, but it should be red color. But now it is gray color because of formalin presence. Is it clear? Because we
Yes.
don't use formalin in a live person. It's very toxic. Yeah. But some laboratory added in cosmetics, in some creams, unfortunately. As it is very toxic substance. Okay. Next and the last hemoglobinogenous pigment, which exactly we have talked about. We have talk about it is porphyrin. Porphyrin. Too much porphyrin. We can see in disease porphyria, the name of disease porphyria, and it is characterized by porphyrin appearance and exactly this patient, first of all, they are scared by sunlight, yeah, and in like in our clinical manifestation, this patient exactly as vampire, yeah. What can you tell me about vampire? Describe vampire.
Ma'am, pale, heliophobic.
Yes. What else?
And cold by temperature.
Yeah.
Cold body temperature. And
Pale skin because of anemia, yeah, because erythrocytes are
to see-
destroyed. Pale, yeah, all symptoms of anemia, yeah, and even abnormality to some, for example, food using, yeah, they can eat meat, free meat, or even drink blood, yeah. And in truth, this vampire, which is from our, yeah, from some movies, yeah, it is sick person, this patient with porphyria, but people they were scared about these people, and therefore, yeah, they did them as demons, yeah, vampire, yeah, but in truth, they are sick person, has porphyria. Okay, is it clear?
Yes.
Yes.
I have just one question. The patient can't drink blood. You said like something about blood. I can't hear it on that time. About blood.
Yes, I mean that it in the description of vampire, yeah, first of all, yeah, what from these movies, yeah, we know that they drink blood, yeah.
You should watch
But
Twilight.
in truth, in every anemia, patient wants to eat something abnormal, yeah, for example, not boiled meat, yeah, exactly with blood, meat with blood, yeah, or eat, for example, I don't, some abnormal, yeah, like this, what could it be? Something, even some abnormality. If you, for example, here, if you have workbooks, yeah, from your colleagues, from your mates, older mates, yeah, in fourth book, it will be about hematology, And we have given all features of ferm deficiency anemia, and there are a lot of symptoms, yeah. And blue sclera and another symptoms, but the same it will be in porphyria instead, and also it will be porphyrin manifestation, porphyrin accumulation manifestation, which because it gives brownish, dark brownish color, and therefore changes of exactly tissues, changes of teeth, abnormality of some disorders, because very often develops in children, yeah, and they have abnormality of the development, different tissues.
Okay, ma'am.
But this disease is rare. Not often we can see these patients, yeah. Okay. Do you have questions about hemoglobinogenous pigments?
No.
No, ma'am.
Do you have questions about lipidogenous pigments?
Lipidogenous.
Yeah. We have talked already about it a little bit, therefore I'm asking, do you have questions or not? The main from them lipofuscin, and I have given a mechanism of its appearance.
So, ma'am,
If you
Yes,
need,
ma'am.
I will repeat.
so in lipopigment, we will include lipofuscin, lipochrome, and some other also, or is it just only these two? For the lipopigments, we will include lipofuscin, lipochrome.
And
That's all.
anything else, ma'am?
Lipofuscin, lipochrome, yes.
That's all. Okay. Because in book it was given something like pigment of vitamin E.
Enterochromaffin cells. Yeah, vitamin E deficiency. Yes, you can add it. Yeah, you can write 3. Vitamin E deficiency, because it is also lipid containing pigment. Yeah, but the main what should you understand that it develops because of destroying of own cellular structures, membranes,
Containing
and
lipids.
lipids from it exactly coagulated exactly and accumulate in cells and extracellular space, like make a grains of this pigment.
Okay, ma'am.
Yeah, this is the main, yeah. And they have brown color. According to them, we can use specific staining for fat. Sudan 3, Sudan 4, osmic acid. Yeah. Okay. And next, we should talk about proteinogenous or tyrosinogenous pigments. There are pigments here which exactly appears because of tyrosine metabolism disorder, yeah, and it is three pigments, yeah. It is melanin, enterochromaffin cell granules, exactly pigment, and adrenochrome. Yeah, 3 pigments you have to know. They have brownish black color. It has, yeah, the main exactly, yeah, mostly we can meet exactly from them exactly melanin, yeah, because it's our normal pigment and usually we can see it. For disorder of melanin accumulation, it is typically for this kind of dystrophies, yeah. And there are 2 kinds of melanin disturbances: hypermelanosis, too much melanin, yeah, hyper, and hypomelanosis, if melanin amount is decreased. 2 kinds, yeah. And according to classification, you have to know different kinds because there are diseases and sometimes even they have very specific terms and you have to know about it, yeah. Hypermelanosis First of all, we have to know that it is divided on general and local. Yeah, general, it exactly, we can see too much melanin everywhere. Local, just in some part, in one organ or in some part of skin. Yeah, melanin, it is a protein which exactly synthesis of this protein happens in melanocytes. Melanocytes, they are neuroectodermal cells, because it appears because of from neural tube in embryogenesis. These separate cells are spreaded exactly in organism. Mostly we can see the cells in the skin, and it gives, because of presence of melanin, it gives different colors. Yeah, different colors of the skin. Also, but not only in the skin, exactly, we can see melanocytes with melanin. Here we can see in the eyes, in adrenal glands, in the intestine, and another organs. Yeah. What else? Yeah. Brownish black color it has. Yeah, hypermelanosis, general and local. General hypermelanosis is divided on two: acquired and hereditary. Hereditary general hypermelanosis is pigmental xeroderma. Yeah, increasing amount of melanin and melanocytes. Clinically, it is characterized by exactly, patients are afraid by sunlight. They are scared by sunlight because the skin and another tissues are very sensitive. Yeah, they have too much melanin, but it leads to hypersensitivity to sunlight. It is hereditary. Yeah, and acquired general hypermelanosis, mostly we should talk about Addison's disease. Addison disease, it is acquired condition. It develops because of adrenal gland injury. Usually it is tumor or tuberculosis.
Tuberculosis.
Yeah, tuberculosis, a tumor, which exactly appears in adrenal glands. It leads to decreasing production of adrenaline and another, yeah, catecholamines is decreased, yeah, as feedback to decreasing of adrenaline and noradrenaline. Hypophyse, yeah, pituitary gland, starts increase amount of ACTG, adrenocorticotropic hormone. And adrenocorticotropic hormone, it has direct connection with melanin stimulating hormone, which also is produced in hypophyse, in pituitary gland. Melanin stimulating hormone, it exactly increase activity of tyrosinase in melanocyte. Therefore, we can see the connection between ACTH, adrenocorticotropic hormone, and
Ma'am, I think we should go for the Skype conference because in this Zoom there is too much interaction.
Do you think that in Skype it's better?
Yes, ma'am.
Maybe the last time it was very bad connection in Skype, but yeah, maybe we can try. Okay, let's
Sure.
continue. Yeah. Okay, what was the last?
Addison's disease.
Okay, did you understand Addison's disease mechanism?
Yes, ma'am.
Okay. Therefore, do you have questions about general hypermelanosis? Not questions. Okay.
No,
very
ma'am.
Okay, therefore, local hypermelanosis, you have to know a few examples of them, yeah? Local hypermelanosis, or also we can name as hyperpigmentation, if we are not sure about it, yeah? If exactly in the way of investigation, we are not sure about diagnosis, we can, or we have to describe this condition, we have we have to use exactly hyperpigmentation, yeah, hypermelanosis term also. And you have to know a few examples, yeah. First of all, it is nevus or nevi. It is a benign tumor. For example, we have a lot of these benign tumors. Yes, there are nevuses, which exactly appears as the local accumulation of melanocytes, but it is benign tumor of melanocytes. It can be hereditary or congenital, exactly, or it can be acquired. It can appear exactly, yeah, in the life. It is a benign tumor, yeah, malignant tumor, and it is the most malignant tumor from melanocyte at all, from all tumors. It is one of the most malignant tumor is melanoma. It is a malignant tumor from atypical melanocytes. Sometimes, very often, it appears exactly like primary, yeah, it appears, yeah. And but sometimes exactly nevus can be transformed into melanoma. Therefore, we should be very very safe according to this nevi, because in trauma, if too much trauma or injury, repeated injury very often can lead to malignization, and this nevus transforms into melanoma. Because of origination, because it is originated from neuroectodermal cells, it can give metastasis in pia mater, yeah, and therefore it is very dangerous. What else you have to know? Okay, I told about, yeah. What exactly can be tell about melanoma, yeah? How can we recognize melanoma? First of all, it is it has black color, brown black color, it depends. From clinical manifestation, which exactly are usually for melanoma, it is sensitivity. If it is exactly, yeah, sensitive to touch, or even patient can feel some pain in it, therefore it's very bad sign, and we can think about melanoma in this situation. If it grows, if it increases in size, it becomes outstanding or becomes wider, yeah, it's very bad sign. Therefore, it means that it is melanoma. If it changes the color. Yeah, it becomes another color. It becomes darker, or we can see a few colors in it. Yeah, it will be bad sign exactly inside of melanoma. We should think about melanoma in this situation. Yeah. Okay. I have given exactly 2 examples of local hypermelanosis, local pigmentation. Yeah, nevus, melanoma. Also, you have to know large intestine melanosis. Yeah, it is hereditary disease, which exactly characterized by large intestine injury. Yeah. Black acanthosis, it is thickening of acanthus layer of the skin, middle layer of the skin, and accumulation of pigment in it. Yeah. And what else?
Lentigo.
Yeah, and lentigo, melasma also we can, chloasma, melasma we can give as example, and lentigo. Lentigo, usually it has coffee-like color. It's bigger than nevus usually. It isn't outstanding. It's flat at all, smooth. Yeah, and it could be coffee-like color usually. Yeah. Lentigo. Okay. About hypermelanosis. Do you
Ma'am,
have
can you
question
repeat? Ma'am, can you repeat lentigo once again, please?
about local hypermelanosis?
Yes, ma'am. The lentigo.
Lentigo.
Yes, ma'am.
Lentigo. It is pigmented, exactly spot, pigmented. It has usually, very often, it has coffee-like, light, like cappuccino-like color. It's lighter, usually than nevus. And it is flat, usually, and it has irregular shape. Very often nevus is round or a little bit oval. But lentigo, it could be even not clear exactly, not clear, exactly irregular shape.
Teacher, so lentigo is not same as freckles?
Not same as?
Freckles, like the appearance of freckles, the
Freckle.
spots, freckles.
I don't understand what is freckles. Can you
Freckles.
spell?
Веснушки.
No, it isn't.
Freckles.
No,
Brown spots on face.
No, freckles, it isn't lentigo. Freckles, it is permanent pigmentation. Yeah, it's like, yeah, because of sunlight, sun influence, it appears in some period, and after some time it will disappear. But lentigo, it is stable pigmentation. If it appears, it's very difficult to disappear it. It's a problem for patient, and even from lentigo. Lentigo also could be transformed in melanoma. Even we have melanoma, subtype of melanoma, lentigo, malignant melanoma, because it looks like lentigo. Is it clear?
Yes, ma'am.
Yes. Okay. Okay, do you have questions about local hypermelanosis? No. Okay, therefore, let's talk about hypomelanosis, yeah? Decreasing amount of melanin, yeah? It could be acquired just 2 kinds, yeah? In classification, general and local, yeah? General, it is always hereditary. It is albinism, yeah? If a patient doesn't have melanocyte or they are not functional exactly. Yes, they don't give function. They don't produce melanin. And therefore, it has very white color of the skin, red, exactly, red eyes, yeah, because any pigment, just vessels we can see, yeah, in the eye. The same according to hairs and another, everything is white because of absence of melanin, total absence of melanin, yeah. And local, it could be very often quiet, appears exactly, yeah, and progress. It could be endocrine system disorder, or after some trauma, it could be if in some region patient lost melanocyte. Yeah, in this region, it will be a white color area, depigmented area, yeah, without any pigment. And the name of this area, the name of this, the term of this pathological condition, which exactly when we can see this area of depigmentation, it is vitiligo. It is written like, yeah, like Latin vitiligo, vitiligo. It is specific, exactly specific term according to local hypomelanosis. Is it clear?
Yes, ma'am.
Yes.
Yes. Okay, do you have questions about proteinogenous pigment disturbances?
No, ma'am.
No questions, yeah.
Teacher, there is another leukoderma.
Yeah, it is leukoderma, it is old term, yeah. In exactly in modern science, usually we use vitiligo, and but pay attention. For example, in dermatology, leukoderma term dermatologists use according to syphilis. In syphilis, specific depigmentation, dermatologists name as leukoderma. In another diseases, it will be vitiligo. Is it clear? But for pathomorphology, it doesn't matter. For us, it doesn't matter the cause. Yeah, just in terminology, some disturbances we have.
Teacher, vitiligo, it is an autoimmune disease due to
Often, but not
autoantibodies.
always. Not always. Yeah, it's very often autoimmune or genetic. Exactly. Yeah, the hereditary disease. Endocrine disturbances very often. Yeah, but mostly it was described and investigated autoimmune origin of this disease. And it's very difficult to treat it at all. Yeah, but and we can change, we cannot change this situation. Yeah, if it appears this depigmented area, it means that melanocytes are absent at all. It's impossible to implant melanocytes, yeah, because the reserve cells exactly are absent. Just some makeup, like some permanent makeup, some injection, exactly, yeah, injection of pigment in it in time can help. The task of doctor, yeah, for vitiligo to stop of progression. Yeah, we use different treatment to stop of enlargement of this depigmented area, because it means that exactly patient is losing melanocytes. Melanocyte will die. Yeah, therefore our task to stop this apoptosis, like apoptosis development, yeah, because and sometimes we even don't know what does lead, why does it happen. Very often it happens, unfortunately. Yeah, if it was trauma, it's understandable for us, and we understand that this area it's impossible to have this, but progression can't develop because it was trauma. But if it is autoimmune disorder, if it endocrine diseases, yeah, we should use some specific treatment according to it. Okay, what else? What another questions do you have? Do you have questions?
No, ma'am.
No. Okay, next. What should we talk? We have finished with pigments, yeah, exactly, yeah. And now let's talk about nucleoproteins, because except pigments, also you have to know about nucleoprotein disorders. There are 3 diseases exactly, yeah. Gout, yeah, do you remember them?
Yes.
Yes, ma'am. Accumulation of
Gout,
uric acid.
uric acid infarction, and stone,
Urolithiasis.
urolithiasis, or stones in exactly in kidney, yeah, kidney stones we can use. Urolithiasis, it means, yeah, kidney, yeah, urine system, and lithiasis, lithium means stone, yeah, kidney stone disease. The main for it, and exactly you have, no, you will have questions in every of them, yeah. Uric acid infarction develops exactly in newborns because of hereditary severe metabolic disturbances, and morphologically we can see infarctions, kidney infarctions, because of blockage of ducts because of this salt accumulation, yeah. And newborn has a severe kidney failure because of it. Therefore, the name of the disease is, the name of this condition is uric acid infarction. Very difficult condition, yeah. Next, about gout. Yeah, gout is also characterized by uric acid salts accumulation, formation of these deposits. But before, in gout, and also clinically we can identify it, increasing amount of uric acid in the blood and increasing amount of uric acid in urine, yeah. And you have to know terms. How should we name increasing uric acid in the blood? How should we name it?
Hyperuremia.
Hyperuricemia.
Anemia.
Hyperuricemia. And hyperuricuria, it is about urine. Hyperuricuria, yeah? Is it clear? And except this blood changing, yeah, biochemical changing in the blood, also we can see deposition of salts, uric acid salts around joints, yeah. And a patient has severe pain because this acid irritates tissue around this joint, skin, subcutaneous fat tissue, all this muscle tissue. They are irritated and injured by uric acid, and patient has severe pain, and we can see deformation of this joint because of salt formation, yeah. Usually it caused by using, if patient, for example, if patient disturb exactly diet, yeah, if he ate meat, first of all, it is exactly proteins, yeah, proteins from meat and another kind of this food, yeah, they should exactly be strong in diet. because in disturbance of diet, exactly this problem happens. This deposition starts. The same uric acid stone deposits, exactly we can see in kidney. In kidney happens the same. As a result, kidney failure and kidney deformation, some fibrosis, sclerosis, cyst formation in kidney develops because of these disturbances and blockage of tubules, renal tubules, because of uric acid depositions. Okay, is it clear?
Yes, ma'am.
Yes. Okay, what else? From mineral disturbances, you have to pay attention to copper disorder. You will have the task about it, and calcium disorder. It is the main. From minerals, what should you know? Yeah. Calcium disturbances, it is calcification or calcinosis. Yeah, calcification, calcinosis, it is the same. It means accumulation of calcium salts. You have to know classifications. There are 3 kinds of calcification, yeah, and you have to know specific staining. How can we understand that? In H and E staining, calcium salt deposition, they are dark violet. It helps us, but we can use cause reaction, KOW. You had this task in your distant work, yeah? Have you seen it? You had the task about clinical task with cause reaction. It was used cause reaction, yeah? And the question, what pathological process is it, yeah? Cause reaction is positive in calcium, according to calcium salt deposition. Therefore, we use cause reaction to identify calcium deposition. There are 3 kinds of calcification or calcinosis. Do you remember them?
Metastatic,
Dystrophic, metabolic.
And metabolic. Okay. Just one of them is local. Local, just in one place. Which of them?
Dystrophic, ma'am.
Dystrophic. Dystrophic happens because of dystrophy and necrosis. It was accumulated, yeah. You will study, you will prepare for the next lesson, yeah. It will be, and you will study exactly necrosis. And except types of necrosis, also it's very necessary to remember outcomes, yeah, what can happen with dead tissue. And as general 12 outcomes, you have 12 ways, what exactly, 12 situations, what can happen with this dead tissue. And one of them is petrification. Petrification, it is the same as dystrophic calcinosis, yeah? Because it is local, it exactly happens because of dystrophy and necrosis, exactly. Instead, dead tissue, or exactly this dead tissue are impregnated by calcium salts, and this calcium salt deposition, we can see instead dead tissue. This petrification or dystrophic calcinosis. Metastatic calcinosis, only metastatic calcinosis, is characterized by hypercalcemia. And very often it happens because of bone tissue injury in some diseases, yeah, osteomyelitis, for example, yeah, or in other endocrine diseases which are characterized by destroying multiple myeloma also, yeah, destroying of bone tissue, and from bone tissue calcium goes in the blood and we can see hypercalcemia, and from blood calcium exactly goes in another tissues in the vascular wall and deposit accumulates in it. And we can see metastatic, general, therefore a lot of deposition in different organs, in different vessels, everywhere. Yeah, it will be metastatic calcification. Metabolic calcification caused by intestine disorder, if absorption of salt and calcium exactly is disturbed. And because of it, calcium and another mineral disturbance develops, and exactly calcium deposition we can see. Is it clear?
Yes, ma'am.
Yes. Okay, and the last, also you have to know about copper disturbance. What name has copper disturbance disease?
Wilson disease.
Yeah, Wilson's disease. Yeah, Wilson's disease, which exactly characterized by copper accumulation. It happens everywhere. Yeah, and clinically we can understand according to accumulation of copper in the eye, exactly as a ring, Kaiser Fleischer ring. Yeah. It will be the color of eye, it becomes bronze, yeah, because of accumulation of bronze shiny, yeah, it's like, yeah, because of accumulation of copper. It's very important. But and also usually copper is accumulated in the liver and brain. Therefore, another name of Wilson's disease is hepatocerebral dystrophy, because mostly we can see cirrhosis, liver cirrhosis because of copper deposition, and brain injury. Even sometimes patient can have psychiatric disorder. Yeah, psychiatric can treat this patient a lot of years, but in truth, exactly excessive amount of copper, I don't know from where, but exactly it is accumulated and lead to this psychiatric disorder or another kind of neurological clinical feature. It depends where exactly the deposition develops. Okay, do you have questions?
Ma'am, can you please explain the specimen of brown lung of brown induration of lung?
Yeah, brown induration of the lung. At the same time, we can name it as hemosiderosis of the lung. Is it clear? Yeah?
Yes, ma'am.
Yeah. But in truth, brown induration of the lung, it has two processes. Yeah? Hemosiderosis and sclerosis at the same time. Yeah? Brown induration of the lung. Therefore, in this situation, we can see lung a little bit is enlarged, a little bit rounder, margins are rounder. It has dense consistency. It has brown color. And macroscopically we shouldn't see more, yeah, microscopically in alveolar walls and in alveolar spaces exactly, we can see accumulation of brown pigment. Brown pigment are accumulated extracellular exactly in space, and also inside in macrophages we can see. Yeah, the name of these macrophages are siderophages and sideroblasts. Two kinds of cells we can see. Yeah, both of them are macrophages, which contain hemosiderin. The difference between siderophage and sideroblast, it is exactly how hemosiderin appears in macrophage. If macrophage have engulfed this hemosiderin, it is siderophage. And if macrophage makes, produce this hemosiderin, it is sideroblast. Firstly, first of all, exactly we can see accumulation of macrophages engulf exactly and becomes siderophages. But later, a lot of macrophages exactly come in this region because of excessive accumulation of hemosiderin, and some of them start to produce hemosiderin inside. And in this situation, it's like a sign of progression. And the macrophage which produce exactly this hemosiderin, it is sideroblast. Is it clear?
Yes, ma'am.
Okay, and how can we recognize it? We can see brown pigment in them. We have to use Perel's reaction microscopically, and Perel reaction, Persian blue reaction, gives blue color, and according to it, we can understand that it is hemosiderin. But except the hemosiderin accumulation, also we can see sclerosis, overgrowth of dense, mature connective tissue, which gives exactly hardening of the lung parenchyma. Is it clear?
Yes,
It happens because of congestion, blood congestion, venous blood congestion in the lung.
Okay.
Chronic, exactly chronic congestion. Okay, what else? Good enough question.
Teacher, what is the difference between lipochrome and lipofuscin?
Lipochrome, we can see they have a different molecular structure. Morphologically, they are similar, just according to reason, and according to light, it has yellowish color. Lipofuscin is brownish, more brownish color, but it is subjective difference. First of all, it is according to the cause. Because lipochrome, only in some diseases we can see this lipochrome. It happens rare, but lipofuscin, it exactly in atrophy, in exhaustion, in old patient. It's like pigment. Another name of this pigment of oldness. Because in old patient, with aging, we can see lipofuscin accumulation.
Okay. How is lipochrome produced? Like, what are the reasons for this?
Because of ultrastructure disturbance also. Another biochemical mechanism, and therefore biochemical structure of pigment is another. There's a biochemical difference between them, and cause. They have different causes. If I find more information, I will send you exactly directly. But usually, if we are talking about lipidogenous pigment, because lipochrome, and at the same time we can see a few lipochrome and lipofuscin. In this situation, if we can see lipofuscin and a few lipochrome, we have to put diagnosis of lipofuscinosis, brown atrophy.
Ma'am, can you please explain the brown atrophy of heart?
Description, you
Yes,
mean?
ma'am.
Some of students gave me full description. Brown atrophy of the heart. The heart is decreased in size. It's smaller. It is V-shaped. yeah, because apex becomes more acute, it is V-shaped. From outside, exactly, we can see coronary vessels. Coronary vessels are prominent. They are visible because of subepicardial fat adipose tissue absence, yeah, because it disappeared. And we can see coronary vessels. In healthy heart, we shouldn't see coronary vessels. In cut surf, if we cut exactly myocardium, we can see that myocardium is brown, and we can understand why is it brown. In microscopical investigation, we can see lipofuscin, brown pigment granules accumulation in cytoplasm of cardiomyocytes. Okay, what else? Also, yeah, I didn't tell about, yeah, after we cut, we can see that exactly the heart wall is thinner, yeah, thinner than normal, it is weak, like flabby, yeah, and we can see brownish color. Okay, what else? What another questions do I have?
Ma'am, what about aortic atherosclerosis? Description.
Exactly, atherosclerosis or lipidosis, because they have different description.
Atherosclerosis.
If we are talking about lipidosis, it will be as example of stromal vascular dystrophy, yeah, exactly cholesterol accumulation. In this exactly in this macrospecimen, we can see yellowish patches, yellow stripes, exactly, yeah, in the aortic wall from inside, from endothelium side. And aortic atherosclerosis, aorta is deformed, yeah, it is, we can see irregular thickness of the aortic wall, it is deformed, it isn't smooth, it isn't exactly, in some region it is narrowed, yeah, lumen is narrowed, in some region it is expanded, therefore deformation. Aortic wall, it's hard, sometimes like we can see like stone formation in it, yeah, and in some regions we can see local thickening. This local thickening, they are atherosclerotic plaques, which exactly consist of lipids and connective tissue growth.
Okay.
If we cut, yeah, if we dissect aortic wall, it will be very hard, and even some like stone, like if we cut stone, we can see specific sound, the same sound we
आए
can
थे और पीछे से आवाज आई थी हम लोग को ना सा एक सेकंड के लिए कैमरा बंद कर रहे थे फिर आगे थे बात कर रहे थे कैमरा बंद
the same sound we can hear if we cut this exactly atherosclerotic changed aorta.
Okay, ma'am. Ma'am, how it is different from aortic atherocalcinosis?
It is exactly aortic atherocalcinosis, because the last stage of atherosclerosis is atherocalcinosis. It means in the last stage